Okay, we're going to start talking now about head and neck ultrasound. A lot of topics here, very dense amount of material here. I'm going to go through it relatively quickly because we have a lot to cover. And it ranges from neurosonology or transcranial Doppler, looking in the brain at the vasculature. We look at the carotids. We're going to look at the facial bones, look in the peritonsillar region, so what's going on there, and the trachea and the thyroid. And then finally we'll end it with ocular ultrasound. So in terms of transcranial Doppler or neurosonology, you can actually make out a lot of the vasculature in the brain using ultrasound. Now a lot of people don't know that because they think about the skull being in the way and everything and reflecting the sound, but actually there's a few little windows where you can peek into the brain and you can see the anterior cerebral artery, you can see the middle cerebral artery, the posterior cerebral artery. You can also make out the vertebral arteries as well. And when there's a block, or where there's a narrowing of the artery or stenosis, we see the flow velocities really jump up using the Doppler. We can calculate we can measure the velocities, and we see the mean flow velocity really jump through the ceiling when there's stenosis. So that's kind of what you're looking for. And you can actually also identify where there's been a total occlusion. And there's been a lot of work looking at, in patients who are having a stroke, not only identifying which vessel and stuff with ultrasound, but also potentiating the effects of a clot-busting drug like TPA. Using smaller doses of TPA because it has a lot of side effects. You can use smaller doses, and then when the TPA arrives at the location of the clot, you can then activate the TPA or potentiate its effects using ultrasound to kind of help increase the surface area for the TPA to work on, the surface area of the clot for the TPA to work on. Anyways, a lot of cool stuff going on here. It probably has a lot to do with the future of neurology and neurosonology, but we're just going to talk very briefly about, sort of what it looks like on ultrasound. So the transtemporal approach, where the skull gets very thin, the temporal bone, the low-frequency transducer, like a 1 megahertz probe, can penetrate right through that window and into the vasculature. And this is what brain sort of looks like on ultrasound. This is all brain parenchyma here. Basically, it looks like, thyroid or liver or something. I think probably more like liver than thyroid to me, but that's the idea. We put the little sampling gate right here across this vessel right here, the MCA, and then we can see this waveform here using Doppler. And you can also look through the ocular area in infra-orbital approach. You can look behind the base of the skull, a sub-occipital approach. And you can also actually look below the mandible and see all the way up to the siphon of the carotid artery through underneath the mandible approach as well. So it's really 4 windows. But probably the easiest one is this transtemporal approach. The easiest one to sort of get started here. There's 4 different locations to place the transducer along these bones here. And keep in mind that in older patients, and actually in women, these skulls tend to be a little thicker. I know it's kind of funny, but it's kind of true actually. And with ultrasound, it's a little bit harder to see that. But you can definitely see the anterior circulation using this transtemporal approach.
I'm just scanning above his zygoma right here, and I'm basically doing a posterior view. I'm going to the median and the anterior, and then the frontal view right here.
So those are those 4 windows that you just saw Alan clearly identify. Now, Alan's going to show you the important vessel in the brain here, the MCA.
I'm going to color mode, and here I see the MCA and the ACA, and what I'm going to do is I'm going to put Doppler on. Oops, back here, and I'm going to hit Doppler again, and what I get is essentially is MCA Doppler on pulse wave. This is the systolic flow, and this is diastolic right here.
Yeah, so this is just using one of our machines that we have available to us, sort of off-the-shelf technology to pretty easily insonate the cerebral vasculature. And when you have an MCA stenosis, it's basically elevated peak systolic velocities. And so we can see here that in this MCA, there's sort of on this, this is not an ultrasound down here, this is a CT angiogram. And what we see here is a sudden dropping off of the contrast material. So there's stenosis right here. Over here it's patent. Over here it's occluded. And so this is the Doppler waveform that corresponds with this right MCA. Over here, this left MCA appears normal. This is what normal velocity waveform looks like. You can see here that the velocity, the peak flow velocities go off the top of the screen and have nowhere else to go, and so the machine brings it up the bottom of the screen. And when that happens, when it goes off the top and comes back up on the bottom, that's called aliasing, that the velocities are so high it's aliasing coming back along the bottom here. Not a critical term to know about, but that's what you see here when you see the velocities coming right off the top of the screen. Now we're going to talk about the carotid arteries, and a lot of people think that the carotid arteries are a window to the coronary arteries. That you can, if you see disease there in the carotid artery, that it corresponds to other disease going on in the rest of the vasculature, particularly the coronary arteries. And because the carotids are so easy to get to, they're like right underneath the skin. I mean, they're just sort of jumping out at you as soon as you place the transducer on the skin. So you can use a nice high-frequency transducer to see these beautiful vasculature right up close on the screen there. And you can see both the intima and the media, and they're involved in the atherogenesis and the lesions that we can see start to stenose or occlude the carotid artery. And what happens is you have the intimal thickness, the fibromuscular hyperplasia. As you get older, that's a normal thing. But the medial thickness, or you can see smooth muscle hypertrophy, that's associated even with simple conditions like hypertension, which a lot of people have, even in the absence of an atherosclerotic plaque. So that's what we're going to be really looking at using ultrasound. And so how accurate is it? Well, the CIMT stands for the carotid intimal medial thickness. That predicts future coronary heart disease events in this study, and it showed that basically this is the carotid intimal medial thickness, which I'm about to show you how to measure. If it's less than 0.6 millimeters, then that shows a very low risk for having an incident. CHD is defined as either a heart attack or cardiac death, and so the coronary heart disease incidence is this y-axis here. So it's not surprising when you start to think about it, as that carotid intimal medial thickness starts to get larger and larger and larger, the odds of having a heart attack or dying from cardiac death go up as we go here. And so I think this is one way to kind of help show your patients right there at the bedside that they really should be taking their antihypertensives and also their anti-cholesterol drugs, because I think this will showing them their intimal medial thickness and a graph like this will help them be sort of more compliant, I think, with those types of medications. And it hasn't really gained a lot of traction because there hasn't been access to ultrasound until very recently. In other words, if you're, let's say, a primary care doctor or a cardiologist, you would have to refer your patient out to get an ultrasound, and then they would come back. And the way this data really works is you do serial ultrasound exams every 3 to 6 months, which really isn't that sort of convenient or feasible to do that on a large scale. But they did do it in this study, and they had a lot of patients. You can see the N there is very, very high. It doesn't correlate early on as well in women, but as you get to this larger thickness here, it starts to have a better correlation. And the same thing is true for strokes, actually. So when you measure that carotid intimal medial thickness, that your odds of having a stroke on this y-axis here go up as your thickness gets,
as your carotid intermedial thickness gets larger and larger, the odds of having a stroke actually go up as well. And not going to walk you through this whole sort of pathway here, but you can imagine how if you're working in primary care or something, you could take this type of data and combine it with some type of algorithm to decide at what risk your patients are. So if your carotid intermedial thickness, here it is, less than 50 percentile or greater than 50 percentile, or you actually visualize a carotid plaque, which is an actual part of the carotid artery that is severely narrowed from a plaque on it, then there's other factors going on here. You can decide how risky your patients are here and decide what to do next with them. Now, how do you measure it? Well, if you look at this vessel here, a schematic diagram, this is towards the head, this is towards the feet, and the common carotid is along here, and as it goes towards the head, it bifurcates into the internal carotid and over to the external carotid. And we can see that kind of happening here. This is, sort of going along here, and then it suddenly bifurcates into the internal carotid and then sort of down to the external carotid. And it's at this region right before the bifurcation, this region in here that we like to measure. And the intermedial thickness is really measured in the common carotid artery, right at that level of the bifurcation, what's known as the carotid bulb. And because of this tubular shape the vessel has here, getting a good perpendicular location relative to the ultrasound transducer's beam, and basically gives you very, very nice images of the carotid artery. You can turn that frequency up and get beautiful images here at this location. And it looks like this when we're measuring it. We try to kind of trace it along for about a 1 centimeter length along that posterior wall. So this is the anterior wall of the carotid. This is the posterior wall. And as the sound goes through sort of the neck muscles and then it reaches the carotid, the fluid, the blood in the carotid, is low attenuating material, and so that's why the posterior wall of the carotid is very easy to visualize, and we can see this little separation here, and that's the intimal medial thickness. So you just measure from sort of this wall down to this wall, and you would drop a caliper right along here, and that distance hopefully is small. Around the 0.6 or even smaller range for the young models that we'll be using this on this week. But if you took it to a patient who was much older or had a lot of known coronary heart disease, you could see this thicken out quite a bit actually. So something to think about. This carotid artery measurement stuff. Here we are with the transducer in a longitudinal plane. Now, what we're going to do is move on now and talk about some of the bones. We did a lot of musculoskeletal last week, but we're going to sort of remember some of those techniques and bring it to the face. And so the zygoma is actually articulates with the temporal bone here laterally, and then it articulates with the frontal bone here superiorly, and then with the maxilla going medially. And so a zygoma fracture will have usually 2 fracture lines, as in the case of any ringed structure. There's usually broken in 2 places. You can think about some of the rings in the pelvis. That happens as well. But we can see the various bones here on ultrasound. Actually, we can see the frontal bone quite easily, and we can make out the maxilla as well. Even the nasal bone is seen quite easily on ultrasound. So when we're looking for a fracture, specifically of the zygomatic arch, this is sort of the technique that we're going to use. And here's Alan demonstrating that. You just take that gentle curving technique from the tragus of the ear all the way over to that nasolabial fold, and the good thing is you can compare it to the other side. And once in a while, you'll see that infraorbital nerve foramen sort of drop down, and it's pretty easy to actually make out. So the infraorbital nerve foramen where that nerve pops out, and that's a common place we do nerve blocks when we're doing sort of
painful things to people's faces in the emergency department. We find that infraorbital nerve foramen and bring a needle down to it and block up that nerve. So just keep in mind that for the zygomatic arch and looking at the maxilla, you want to start that tragus with the indicator towards the patient's scalp, and on the screen that indicator is on the left side of the monitor. Therefore, the left side of the screen indicates the superior aspect of the zygoma, while the right side of the screen indicates the inferior aspect of the zygoma that corresponds to this lower part of the transducer, the indicator being on this part of the transducer towards the apex of the skull. The bone is very hyperechoic, and we can see easily the shadowing coming down here in the lower field. And basically, you just sort of slowly scan along the area from the tragus to the maxilla, along from the tragus to the nasolabial fold, where you're going to see the maxillary process of that zygomatic arch. And if you're looking for fractures, obviously, as we're doing this, when a patient comes in after they have blunt trauma to the face, and if there's any discontinuity or depression along that hyperechoic cortex of the zygoma, then you're suspicious for a fracture, although it's easy to identify that little sort of step off over here. But that's just, again, that infraorbital foramen. You can always look on the other side if you have any doubts. Now, about 70% of mandibular fractures are subcondylar. This is important as condylar fractures, especially non-displaced fractures, are difficult to diagnose with ultrasound. The zygomatic arch crosses anteriorly at the level of the tragus. Another point is that the masseter muscle lies superficial to the mandible and from the condyles to the angle of the mandible. So the operator really needs to look deeper for the mandibular cortex when doing one of these ultrasounds. So the next one video you're going to see here is ultrasound of the mandible. And so for mandibular ultrasound, you're going to start at the tragus of the ear with the indicator pointed anteriorly. Superior to the starting point, the zygomatic arch crosses superficially over the mandibular condyle. The soft tissue superficial to the mandible is that masseter muscle, and right along here. And many times you see it in cross-section on ultrasound at that point. So you're going to slowly scan inferiorly, noting any discontinuity or depression along the cortex of the mandible. And then once we arrive at the angle of the mandible, we'll see the masseter belly sort of disappear. And then you can rotate the transducer 90 degrees so the indicator is pointing towards the ceiling, as we did over here. And then slowly scan towards the patient's chin. And we will also encounter the mental foramen close to the midline that was seen here on this clip with an arrow. And that should not be mistaken for a fracture. Anytime you see one of those foramens, it looks like there's a step off, but that's just the area where the nerve comes through. You're going to scan the other side as well, especially when it's possible that a fracture could be identified. Remember, the mandible is a ring structure, and once a fracture is identified, an accompanying fracture should be sought. So this is actually what a zygoma fracture looks like. You can see the discontinuity here, the drop-off in the cortex. So the zygoma is going along here, and then poof, there's a drop-off there. And all that is soft tissue swelling, sort of that hypoechoic fluid seen just superficial to the fracture. All that material there. And this is a comminuted mandibular fracture, which means it's in different pieces, and the disrupted cortex is sort of located at two different places there by those green arrows, and you can see sort of accompanying superficial layering of the fluid there from all that soft tissue swelling that's anterior to this whole process. So many times we see a lot of edema or even hematoma formation above these fracture patterns. So one bone is here, one part of the bone is here of the mandible, and then there's a step off, and then there's another bone here, and then the other bony landmark is over here. So this is comminuted, broken in two different places. Now, what about the sinus? I'm not going to go into this too much, but you can diagnose sinusitis actually using ultrasound. And a normal sinus appears like this with some sort of reverberation artifacts here coming down. And we don't make out really any of the posterior, lateral, or medial walls, seeing we just see this sort of anterior spot and then some of this reverberation coming down. But with sinusitis, well, now we can actually make out the walls of the sinus and even the posterior area of the sinus down here. And so I know it looks sort of like this one over here when you first look at it, but if you look closely, you can actually see how this sort of like a snowstorm. You don't really see much. Again, this is anterior, this is posterior. But over here, now there's fluid in the sinus. We can see the conduction of the sound all the way down to that posterior and even this lateral wall. And, you know, sort of I see another lateral wall over here. So one sinus is here, another one is over here. And you can just sort of make out the anatomy a little bit better because it's filled up with fluid. It's easier to do this when the patient's sitting up. And actually, you can even... there's some therapeutic effects of low-frequency ultrasound on nasal unblocking in patients who have chronic sinusitis. And so, you know, with ultrasound, there's sort of more mucus being expelled, and there's also more airflow after the patient gets ultrasound of their sinus. So I don't know how accurate this is. It was published somewhat recently in 2011. A lot of this stuff requires, obviously, more research, but this is something that I found sort of intriguing when I first found out about this, that you can actually use ultrasound not just diagnostically with the sinus, but therapeutically as well. Switching gears, and we're going to talk now about peritonsillar abscess. So the tonsillar pillars can be seen on ultrasound quite easily. In fact, you can even see lymphadenopathy in the back of the throat as well in someone who just has a normal, you know, enlarged lymph node reaction to having an infection in their throat. But the problem is you can also have an abscess cavity start to form adjacent to the tonsil, and this can be somewhat difficult to diagnose clinically because the patient may have a lot of redundant tissue in the back of their throat, and it's not as obvious. Sometimes they're very obvious. You see the uvular deviate to one side, uvular deviation. One thing you got to be careful, though, with when you're using endovaginal ultrasound, like, for example, in this 12-year-old male right here, that you don't call it an endovaginal probe. I like to call it the endocavitary probe or something like the oral probe. Maybe that sounds worse. I don't know. But if you call it an endovaginal probe, they're more likely to refuse the procedure. So usually I give them a little medication to sort of make them feel sleepy, like midazolam. So after a little midaz, and you can give that intranasally, actually, so it's pretty easy to give. And you want to cover the transducer with a sheath. And just as you would do when you perform endovaginal ultrasound, you put a sheath over the transducer, put some gel. What's not pictured here is gel in between the probe and the transducer sheath, because you want to have conduct. You don't have the air up here, okay? And then you simply place the transducer in the back of the throat, and you will see sometimes abscesses. And in this case, there's a needle coming right into this abscess right here on this patient. And so you can guide a needle into the hypoechoic, this is the abscess back here, the hypoechoic debris. Now, sometimes what you have instead, though, are just pharyngeal lymphadenopathy. And so that's what these are here. These are not abscesses here. It looks kind of like that other abscess a little bit, but these are just enlarged lymph nodes. And we can see both lymph nodes here when the transducer is in a transverse plane. We can actually make out both of these lymph nodes. Now, when you first look at that, you may wonder, wait, how do you know those are lymph nodes and not an abscess? Well, you can actually put on some Doppler, and with these lymph nodes appear hyperemic in the back of the throat. This is the large vessel down here known as the carotid artery. This is the hyperemic lymph node seen over here. Do not put a needle in that. That's just a normal lymphatic reaction. On the other hand, a peritonsillar abscess looks like this. Looks like a very large hypoechoic area. This was before drainage, and then we can see after drainage it's basically gone. And so we can monitor the status of the abscess as we go through with ultrasound. This is another example here of a peritonsillar abscess. And what you can do is you can take calipers and measure the distance from the mucosa in the back of the throat all the way down to where the abscess lies. So that's how far you know to place a needle. So what we do is we measure this distance, and we know that, well, the needle only needs to go about 1 centimeter before it's going to start to get to some pus. And it definitely is going to stay away from these large blood vessels back here. And so that's one way we can help guide the procedure. And this is just another example here of a patient who's got a pretty large peritonsillar abscess. All this stuff here is pus. It looks like it's sort of solid at first, but as we push on an abscess, pus will distend, will swirl like that, and that's what can really sort of give away the abscess as you see that swirling pus come along. Again, we know how far we need to go to get the needle to come in. It's just from the posterior oropharynx, this mucosal line right here, all the way down to where this abscess material is. And some of these large abscesses are actually quite easy to drain, although sometimes they're so extensive, they involve a really large area back here that you may not want to attempt drainage yourself in the clinic or even the emergency department setting. You might want to refer some of these more complicated ones to a specialist like an otolaryngologist. But we went for this one ourselves. This is, you're going to see here, a needle sort of coming into this abscess, and that's the ultrasound guided. We can see the needle has made its way. Actually, you can see the distension of the tissue down here, that needle tracking into the abscess. We did inject a little bit of lidocaine. That's what you see being injected into the abscess, sort of to help numb it up a little bit, and then we start to drain this out using ultrasound guidance until all the pus is gone. Moving on to the thyroid, so we can use ultrasound to help diagnose thyroid disease. But usually what happens first is, this is sort of the order that things happen when somebody comes in worried about something going on with their thyroid. They get a bunch of blood tests, and I'm sure you're learning about all that in your classes, which won't go into that. And when one of these blood tests come back abnormal, then the first thing that usually happens next is they get a thyroid ultrasound, where we can differentiate solid from cystic nodules. We can see even solid components of a cystic nodule, whether the thyroid is multinodular, and we can identify and differentiate masses in the neck from thyroid nodules or lymph nodes, and whether or not lymph nodes are enlarged or abnormal appearing. But one thing to keep in mind, I want to really hammer this point home, is that I'm going to show you some signs to say whether something could be more likely to be benign than malignant, some morphology. However, really, to be sure, you need to biopsy all of these lesions. And the good news is you can do that fine needle aspiration or biopsy under ultrasound guidance. So other studies that can be done are isotope scans to see how active a nodule might be, and then other imaging modalities such as CT, MRI, and then a chest X-ray to look for any other abnormalities that could be associated with disease of the thyroid. So ultrasound, obviously very inexpensive, it's accessible, it's not invasive, and therefore it's accurate and sort of describing the morphology of the thyroid, especially in light of the somewhat inaccuracy of just palpating for the thyroid. Now, ultrasound, thyroid ultrasound is definitely good at detecting unsuspected small nodules, and therefore a lot of people feel that ultrasound should be, a good means for detecting early thyroid cancer, because there's an equal rate of thyroid cancer has been shown in palpable and non-palpable thyroid nodules, ones you only see on ultrasound. So that's why it sort of makes sense to look at this with ultrasound. And the anatomy couldn't be more obvious on ultrasound. I mean, it's like right up next to the edge of the transducer, so we can have a nice high-frequency linear transducer here identifying. This is all the thyroid here. This is the trachea, or as some people call it in the United States, the trachea here. And we see the mirror image artifact of the thyroid isthmus. This is the isthmus of the thyroid. We see the mirror image on the other side of the trachea right here. So that's just the mirror image of the isthmus down here, not actually in the trachea, but that's how it looks because of the physics of the situation. And so also keep in mind that the esophagus, although it is drawn very posterior to the trachea, we actually see it usually just slightly on this side of the trachea, on the left side of the trachea. We'll see the esophagus. That's very easy to see. This is just kind of getting at some of the anatomy, some of the longitudinal or sagittal anatomy here with some of those thyroid vessels sort of coming out to play. You can make out those thyroid vessels actually quite easy on ultrasound, both the arterial system and some of the venous system as well, as seen over here. And when we come across a nodule, we can put some color flow mapping on it, and you can actually grade these nodules, where grade 1 is no color flow mapping at all seen inside the vessel, inside the nodule. Grade 2 is where you only see it peripherally. Grade 3, there's penetrating flow through that nodule, which is vascularity, also known as vascularity moderately rich, or high-grade velocity penetrating flow into this nodule and is a vascularly rich flow at grade 4. So this is grade 2. It's kind of only in that peripheral area there. And this is an image here of a thyroid nodule, mostly a cystic thyroid nodule here. There is this kind of mural component seen here with the grayscale. We're not really sure what is going on with this mural component, but when we put some color flow on it here, we can see that it really only involves here, this flow is coming around only around the periphery here, but there is flow within that mural component outlined here by this arrowhead. We can see there's flow that does penetrate into that mural component, that telling us that this is actually tissue and not something else like debris, because sometimes it's hard to tell the difference whether something's really parenchymal tissue versus something that is just sort of artifact, debris, hematoma, what have you. And so, and this lesion was actually biopsied under ultrasound-guided fine needle aspiration, and it was shown to be benign under cytologic examination. This is what Doppler category 3, moderately rich flow pattern to this nodule here. So normal-looking thyroid here. We see carotid artery over here, and we come across the isthmus. This is the trachea. We see some mirror image artifact of the isthmus here. And then the other part of the thyroid that appears normal is down here, but now there's this nodular component to the right thyroid seen here adjacent to the right carotid. And so when we put Doppler here, this is penetrating color flow with moderately rich vascularity seen there. This is category 4, high velocity color flow mapping, vascularly rich, and throughout this thyroid nodule down here. There's some peripheral flow as well, but this one definitely you'd want to be able to biopsy that one for sure with all that Doppler flow to it. Very suspicious looking. This also demonstrates here the role of color Doppler in the thyroid. On the this image over here, we just see some predominantly a solid thyroid nodule. So this is normal looking thyroid down here, and this is all this solid looking nodule here. And then we add some color flow Doppler here. The carotid lights up a little bit, and we can see marked internal vascularity, increasing the likelihood that this is a malignant nodule, and indeed after biopsy this turned out to be a papillary carcinoma. Now what about some red flags that might make us concerned for cancer in the thyroid? Basically, whenever you have a nodule in the patient's male or at the extremes of age, or changes from visit to visit very rapidly, or the patient describes that to you clinically, or if there's if it's larger, greater than 4 centimeters, or if there's any kind of symptoms of like they have a hoarse voice, change in their voice, or difficult to swallow, then you really want to be worried that this could be a malignant lesion. Luckily, the malignant lesions are quite rare. They're usually benign, and many times you need to repeat the fine needle aspiration. If you don't get a good enough sample, they come back in a few months. Or if it looks suspicious, is about 10% of the time, but in that 10%, luckily, most of the time they turn out to be benign. And so right off the bat, about 5% after fine needle aspiration are the malignant ones. So luckily not too common, but common enough to want to aspirate anytime you're suspicious. Now, Graves' disease, you're going to learn about it as a second year, but basically it's an autoimmune disease where the thyroid is sort of overactive, produces an excessive amount of thyroid hormones from the autoantibodies that activate the thyroid stimulating hormone receptor. It stimulates a lot of thyroid hormone synthesis and secretion, and the thyroid starts to really grow rapidly, causing this enlarged, diffusely enlarged goiter. And it has a really dramatic sort of constellation of neuropsychological and physical signs and symptoms. We see this quite often in both emergency medicine and primary care. And it's actually the most common cause of hyperthyroidism in children and adults and adolescents, and usually presents itself during early adolescence. There's a hereditary component to it. It's between 5 and 10 times more common in females than males. It's also the most common cause of severe hyperthyroidism, and basically about 25 to 30% of the people with Graves' disease will also get Graves' ophthalmopathy, which is a protrusion of one, usually both eyes, caused by the inflammation of the eye muscles by these autoantibodies. And so you get this marked proptosis, and you Google this, you get some pretty interesting pictures that pop up when you do this. It's kind of fun. So we can see what a goiter looks like here, just very sort of multinodular enlargement of the thyroid, and they have a very prominent, usually neck. You can see the goiter just walking in the room for the patient, and you don't really even need to use ultrasound on it, but that's what it looks like there. Now, sometimes in these nodules, you'll see some punctate echogenicities, and what you want to wonder to yourself is, is there a cancer there or not? And it depends on if there's comet tails. So here, in this case, there's no comet tails, and so this one is suspicious of a malignancy. And actually, this nodule here was confirmed to be papillary carcinoma under fine needle aspiration, because we see these punctate echogenicities. So when you see punctate echogenicities, think badness, unless you see a comet tail. And this is what that reverberation artifact, that comet tail, looks like. And so colloid crystals will cause these comet tails. And so with benign nodules, there's a lot of times colloid crystals in there that result in comet tails. And so comet tails in the thyroid, good. Here's just a solid thyroid nodule. This turned out to be papillary carcinoma. And this is an example here of a cystic nodule. And under fine needle aspiration, this turned out to be a benign lesion. You can see it's just very simple, very cystic looking nodule with no internal components to it whatsoever. And this is just another image here. We were looking at here of this complex thyroid mass. We see the internal jugular vein, the carotid artery, and it's almost hard to see. It's very hypoechoic with multi nodularity to it. Some parts are hypoechoic, some parts are hyperechoic, and that's the kind of thing you definitely want to refer for a biopsy. Now, what about the larynx? At the level of the thyroid cartilage, the cartilage, as well as the retinoid cartilages, make sort of an inverted a V pattern. We can see that there easily on ultrasound. And actually, one study showed that vocal cords were seen 70% of the time on ultrasound in patients undergoing elective intubation. And you can actually make out the tracheal rings seen below the level of the thyroid isthmus, which we showed on those earlier images, which itself is just below the level of the cricoid cartilage. And so on ultrasound, we can make out here, using a curved transducer, although they turn it up to the resolution mode, high frequency mode, so you get a little bit more penetration. You can actually see all the way down to the vertebral body here of C6. We can see the thyroid gland here. We can see the esophagus just off to the left side of the trachea seen here. So this is medial, this is lateral, and this would be the left thyroid gland seen here. The isthmus is making its way across. And during intubation, actually, we place an endotracheal tube. We can see those prominent comet tail artifacts, reverberation artifacts coming down once the endotracheal tube is successfully within the trachea. So we can make sure that it's in the trachea and not the esophagus quite well. Again, that's that comet tail artifact sign. And this is what esophageal intubation looks like. Here's the esophagus down here. Not that we're trying to intubate the esophagus, we're shooting for the trachea, but as sometimes you miss, and this is an esophageal intubation on a difficult to intubate patient, we can see that comet tail now within the esophagus. And this is a wonderful image here by colleague Dr. Shibata. Thank you very much. And it's pretty rare to see that, but when you do, it's an immediate indication to pull out that tube and put it over here in the trachea before the patient decompensates. Very briefly now, we're going to talk about ocular ultrasound. And the most important thing to keep in mind regarding the anatomy of the eye is, as I think, is that the ora serrata is seen here anteriorly. This is where the retina is attached right out here at the ora serrata. It's also attached always back here, just about always at the level of the optic nerve. So it's always tethered here at the ora serrata, and then back here at the level of the optic nerve. This is the fovea of the eye. Here we can see the optic nerve coming down here with its vasculature. The choroid is the back part of the eye back here, and the retina is attached all the way around at the choroid. I keep saying attached because many times the retina becomes detached, and the patient has all kinds of symptoms of floaters and everything, and they see things in their vision that's floating around. Sometimes it feels like a shade is being pulled down. Usually it's not painful, but if it detaches here at this level right here, lateral to the optic nerve, then it may result in permanent blindness. And so when you have it still attached at the fovea, but maybe the retina is starting to detach over here, that's a true ocular emergency, and you need to find an ophthalmologist right away to laser this retina back down when it's still attached to that area where the fovea is, sometimes called the macula. Anyway, so how do we do these ultrasounds of the eye? Well, you're going to use a high-frequency linear transducer, 10, 12, 15 megahertz range. Patient closes their eye, have the patient look straight ahead, use lots of chilled gel. I say chilled gel because it stands up better on itself. And you're going to scan both eyes in both transverse and sagittal imaging.
When scanning the globe sagittally, aim the indicator towards the apex of the skull. Fan through the entire globe from lateral to medial and back to lateral. The transducer should then be oriented in a transverse plane with the indicator towards the patient's right eye, and fan the sound superior and then inferior and then superior. Initially, the patient should look in a forward direction and the depth adjusted so the eye fills the majority of the screen.
So the technique involves both a transverse and an axial, a transverse, which is an axial technique, and also a sagittal or longitudinal technique, as you just saw. Make sure the patient looks straight, and have them close their eye and use lots of gel. And then the kinetic exam is performed with the patient's help. In order to visualize the entire ocular contents, the patient can be instructed to gaze to the left, gaze to the right, gaze up, and finally gaze down. And this may be repeated several times until you have sufficient information to render a diagnosis. And so I have the patient look all around like that, and that seems to really help. Sometimes when you're in the sagittal plane, it helps to have the patient gaze gaze nasally while the transducer remains fixed, and so you can see the sound going past the lens all the way down to the optic nerve. The lens can cause sometimes some diffraction of the sound and occludes the optic nerve sheath. And so we can see the various structures here. Use lots of gel, that's superior to the eyelid. Gel is way up here. And then we can make out the eyelid here. And then we can see the anterior chamber, and that's the lens seen back there. We can actually make out the iris. This is the iris here, the iris here. Okay, so in between the iris is the pupil. And so what happens is when you shine light in the other eye, the eye that's open, you can actually see this iris constrict. And the pupil will constrict because this structure here and this structure here will move towards one another. And then you want to look in the posterior segment, sometimes called the vitreous vitreous body, or posterior segment of the eye, vitreous humor, and then behind that is the retina attached down at the choroid. And actually behind the retina, you can see a little piece here of the optic nerve sheath coming down as well. And we can see all kinds of cool stuff. We can see lens dislocations. That's what that's going on here. This lens is not over here, but dislocated. We can see intraocular foreign bodies. This is a metallic foreign body. A guy was working with metal and something shot in his eye. And we can see that foreign body here as well, looking in two different planes. Causes some shadowing underneath it. And we can see papilledema also. We know how difficult that can be with the physical exam. And there's that subarachnoid space that's around the optic nerve. It's not supposed to have any cerebral spinal fluid in it, but when you have high intracranial pressure that compresses the optic nerve, then you can that subarachnoid space that's around the optic nerve can dilate as the pressurized cerebral spinal fluid starts to fill it. So in other words, when someone has an elevated intracranial pressure, maybe from a head trauma, maybe from a tumor or other processes, we can look with the ophthalmoscope for papilledema, or we can see the optic nerve sheath widen out using ultrasound. And this is sort of a diagram showing the retinal artery. The yellow stuff here is the optic nerve, and you can see the various layers of the optic nerve sheath. And when fluid gets in there, cerebral spinal fluid sort of slowly percolates in there when you have elevated intracranial pressure through that trabeculated arachnoid space. There's little trabeculations in here. I don't know if you can see that drawn there or not. Well, that causes that whole sheath to widen out. And as that happens, you can actually measure that in ultrasound quite easily. So this is the choroid of the eye back here. We're going to measure 3 millimeters posterior to the choroid. At that level, we can measure the width of the optic nerve sheath diameter. This one happens to be widened. So how wide is normal? You can have up to 6 millimeters in adults and up to 4.5 millimeters in children before it's said to be a widened optic nerve sheath diameter. Here we are measuring just sort of how you do it. You sort of measure from the choroid of the eye, the back of the eye, 3 millimeters, you wait until that number reaches 3, and then you bring up another caliper, and at that level you measure the width of that sheath, that shadow that comes down. And when you have a retinal detachment, what happens is this can sometimes be difficult to diagnose under direct ophthalmoscopy, unless you have the patient really have a dilated eye and you have a really cooperative patient. There's not a lot of there's no trauma, there's no swelling of the eyelids. In any of those situations, it seems to be easier, at least for me, to have the patient just close their eye altogether and put gel on it, and then look with ultrasound. You can see the retina is detached off the back of the choroid of the eye. It always gets the retina is always attached at two locations though: the optic nerve and the ora serrata. And so we can see the anterior chamber there and the lens. And this is one of our machines does 3D. We can see the retina sort of peeling off the back of the eye in this particular view here on 3D ultrasound. Gives you the sense that it's not just a linear thing that we think about on 2D. It's really this whole three-dimensional, envelope that peels off the back of the eye like an onion skin here, seen on three-dimensional ultrasound. Now, this is an example here of retinal detachment. We can see it's tethered at this location, and it's this sort of tethered membrane that is coming off the back of the choroid there as the patient looks around. And as I mentioned, it depends where the retina gets detached. It could be at the level of the macula, and the macula is just lateral to the optic nerve sheath. So here's the optic nerve sheath coming down here, and if the retina is detached, it's off the back of the eye at the level of the macula, then they have sort of less of a good prognosis when this gets lasered back down. Ophthalmologist comes along and uses lasers to get this retina to be attached back in the back of the choroid of the eye there. So that's a MAC off retinal detachment, because you see it's really only tethered right at the optic nerve sheath. And there's another example. This is the same patient. We're just fanning through it now. So as we fan through this eye, we can see that optic nerve sheath, and just lateral to it, it's not attached. And so that's a MAC off sort of funnel-looking detachment. This is a MAC on retinal detachment. So again, this is lateral. This is the optic nerve sheath. this is where the macula is here, and the retina is still attached to that location. Then it abruptly comes off. And these are the ones here that you really want to get lasered down as soon as possible before this part peels off as well. And unfortunately, these are the patients that have the least amount of symptoms. Very vague symptoms in these MAC-on retinal attachments. Compared to the MAC-off, they come right in because they can't see. And the vitreous body, so you can see this yellow line here is the retina. Okay, yellow being the retina there. The retina is still attached, but the vitreous body can peel away from the back of the eye. And when it does that, it definitely peels away. It usually peels away off the optic nerve sheath. So that's kind of how I differentiate, because they look very similar. The attached vitreous body and a retinal attachment look similar. Depends if it involves the optic nerve sheath or not. So if it doesn't, if it peels off the back of the optic nerve sheath, then it's likely a detached vitreous body rather than a retinal detachment. And as the patient looks left and looks right during the kinetic exam, you can see that it looks like clothes in a dryer. That's what a detached vitreous body looks like, especially if you overgain the image a little bit. As the patient looks around, it kind of looks like clothes tumbling around in a dryer. And that's another way to differentiate a detached vitreous body from the tethered membrane appearance of a retinal detachment. All right, well, we threw a lot of pathology in this time. I tried not to do that, but I also think it's a lot of fun to kind of see some light at the end of the tunnel, pun intended. And when you get to the hands-on component, we're going to take a look at that carotid vasculature, the thyroid, maybe even do an ocular exam, and come along those the bony landmarks on the face, and also look into the brain at the middle cerebral artery. All right, thank you very much.